My name is Todd Valines, and I'm a cardiologist at Walter Reed National Military Medical Center in Bethesda. And what I thought I'd talk about today is a commonly encountered problem in medicine, particularly in internal medicine and cardiovascular medicine, and that is syncope. And so it's really important to first start off and define what syncope is, because this can sometimes be confusing. And so syncope is the sudden, transient loss of consciousness. It is not falling and tripping and hitting your head. It is not becoming too intoxicated so that you can't get off the floor. It is not having a seizure. It is a sudden, transient loss of consciousness. And what we're going to talk about today is what are some of the common causes for syncope, as well as how would you evaluate a patient that you encounter with syncope. And so as mentioned already, the first part of this is truly defining, did the person have syncope versus a mechanical fall, and that can sometimes be challenging. And so when we think about what causes syncope, the fundamental pathophysiology is a loss of perfusion to the brain. The brain is exquisitely sensitive to any drops in oxygen content. And so even just for a few seconds, if cardiac output is dropped to the brain, even just transiently, people will lose consciousness. And so think about that fundamental pathophysiology as we go through the differential diagnosis. Now, before we talk about causes for syncope, I think one of the things I'm going to stress right up front is the most fundamental piece of importance, the most important part of your evaluation of a patient with syncope is the history of present illness. I cannot stress to you how important this is. In fact, I tell students you cannot take too detailed of a history when you're talking to a patient who has had syncope, to include how they were feeling prior to the event, anything that they recall, particularly during, just before or after the event, and then subsequent to the event. But not only that, it's important to take a family history, very crucial, the historical details about syncope, whether it occurred during exercise, after exercise, and eyewitness accounts are crucial. So interviewing not just the patient, but many times interviewing anybody, or maybe even making that phone call and interviewing folks who actually witnessed the syncopal event is crucial. So that really the first step in an evaluation for a syncope patient, much like almost any other problem, but particularly in a syncope patient, is a very detailed history. So when we approach syncope, we want to take a history and evaluate the patient with a differential diagnosis in mind, so that it reminds you to ask important questions and to make sure that we get all of the details regarding the event. And so a real simplistic approach to syncope is to literally divide this into cardiac causes for syncope and non-cardiac causes. And then I'm not breaking this down into heart and non-heart simply because I'm a cardiologist. But this is a very, I think, practical way to approach why a patient would have a transient loss of perfusion to their brain. So when we think about cardiac causes, one of the reasons we do this is because things that cause syncope that are related to the heart, oftentimes, if missed, have a very poor prognosis. Now what's nice is that you can break this simplistically underneath the category of cardiac causes for syncope into either structural abnormalities, so any things that would cause a decrease in cardiac output due to an obstruction to cardiac output, a decrease in flow from a structural abnormality. So we can think of things like valvular heart disease. I'll write that where you guys can see this a little better. So heart valve problems. The classic abnormality would be aortic stenosis, or AS. So having a significant obstruction to outflow at the level of the aortic valve. You can think about other stenotic lesions. So when we talk about obstructions, we're typically talking about a stenotic lesion. So mitral stenosis, aortic stenosis being by far more common. But there are other areas for obstruction, such as below the aortic valve. So there are subvalvular, supravalvular obstructions. Things like pulmonic stenosis are less common. And then very, very uncommon would be things like tricuspid stenosis. Outside of the valve, there are other ways in which there can be occlusion to blood flow through the cardiopulmonary circuit, so such as a large pulmonary embolism. hypertrophic cardiomyopathy. So this is an obstruction below the heart, below the aortic valve, where you can get transient obstruction to blood flow due to a very thickened septum and its impact on the mitral valve. And this is particularly true in cases where people are dehydrated or volume depleted. So think about syncope in an athlete who's finished practicing on the football field. And so this is a potential cause for syncope. And this is just a few of the obstructive causes that can cause syncope within the heart. But generally we're thinking about valvular obstructions, any type of vascular obstruction due to a clot, a thrombus formation, a tumor, or anything like that that might invade the heart. And then hypertrophic cardiomyopathy is a dynamic obstruction that occurs below the heart valve. So heart structural abnormalities. The second large cause of cardiac causes of syncope are from heart rhythm abnormalities. So either the heart rhythm goes too slow or the heart rhythm goes too fast. And it really is that simple. And so if you think you either have a bradyarrhythmia or a tachyarrhythmia. And again, I mentioned that all of these things here, if they cause syncope, these are universally carry a poor prognosis unless they're treated. But many of them are treatable. And so think about the patient who has heart block who comes in with syncope, the classic example of a bradyarrhythmia. The treatment, of course, in that patient is generally a pacemaker unless you can identify a reversible cause. The other concerning cause for syncope would be a tachyarrhythmia, a tachycardia. And again, we can break these into supraventricular tachycardias or ventricular tachycardias, with people having things like ventricular tachycardia or ventricular fibrillation being the most concerning and life-threatening. And it's not uncommon for someone to present with syncope as a harbinger of future sudden cardiac arrest. And so when you think about these causes, you can now think about the questions you're going to ask these patients as far as have they had palpitations, have they had dizziness or lightheadedness preceding these events? Have they ever been told they have a murmur? And of course, your physical exam is going to be crucial in diagnosing these structural abnormalities. And then pulmonary embolism, do they have risk factors for this? Although this is a relatively uncommon cause for syncope, but we would think about all of the different symptoms that one would have, such as breathlessness, acute onset, etc. And so I think it's really important to go through these. It's very important to diagnose cardiac causes for syncope because they carry with it such a poor prognosis. Fortunately, the majority of syncope that we see do not have cardiac causes. And again, these are either due to a structural abnormality or a rhythm abnormality. So the fundamental evaluation you can see starting off with is a history of present illness, a very detailed cardiovascular exam, and then an electrocardiogram. And that is the fundamental kind of 1, 2, 3 of what we're going to do in every patient who presents with syncope. A very detailed history, a very focused examination, particularly cardiovascular examination, and every patient we're going to get a 12-lead EKG. There are some very unusual rhythm abnormalities that oftentimes we will detect on a resting EKG, even though the patient is currently feeling fine. So these are things that are rare, but important not to miss, such as things like long QT syndrome. We had EKG evidence of hypertrophic cardiomyopathy, arrhythmogenic RV dysplasia, and a few other things that would be very noticeable even in a resting EKG. And so always start with these three findings. There's a whole list of non-cardiac causes that cause syncope. Unfortunately, these are the most common causes. The most common is this group of diseases that we call neurocardiogenic. And that's a very confusing word. It goes by several other names. So some patients might describe this as what's called a vasovagal syncope. And this is kind of the common faint, if you will. And the pathophysiology is that whatever stimulus it may be, whether it's seeing blood, whether it's standing up too fast when you're dehydrated, whether it is having finished a long workout and being vasodilated and somewhat volume depleted, regardless of the stimulus, you activate the vagus nerve, and this causes a drop in heart rate and vasodilation, usually a combination of those two, and that happens suddenly, transiently. You get cerebral hypoperfusion, and you pass out. Now, what's interesting is this is by far and away the most frequent cause for syncope, and typically in these patients, unlike patients who have sudden arrhythmias, they'll often describe a prodromal symptom, such as having some dizziness, tunnel vision, lightheadedness, that they felt nausea, which is an association due to vagal output. And they often will have a history of having near syncopal events that feel very similar to this, where they've been able perhaps even to abort syncope in the past by sitting down. Typically they don't have palpitations or any of the high-risk features like chest pain or shortness of breath, and their cardiac exam is generally benign, as is their EKG. And the history is really classic in this because we don't have great tests to test for this etiology. There are other non-cardiac causes. These are patients with what we call orthostatic syncope, where they lack the ability to compensate for sudden standing. They have blood pooling in their legs and pelvis veins. They're often on antihypertensive therapies, and it occurs often in a situation where they are volume depleted, so they've not been eating or drinking normal amounts. Maybe they have an acute illness that's caused them to lose lots of fluids, or they've been on a diuretic, and lots of different scenarios here. And many times you'll notice that when you see these patients and you stand them suddenly, or you do orthostatic vital signs, you'll see significant drops in systolic blood pressure, diastolic blood pressure, as well as increase in the pulse rate that suggests to you, as in combination with your exam and their laboratory evaluation, that they are indeed volume deplete. And these are getting clinical diagnosis. So neurocardiogenic syncope, orthostatic syncope, there's also syncope that can occur in various situational syncope that's very similar to vasovagal, such as when patients cough or if patients are choking or having a bowel movement. That can oftentimes stimulate the vagus nerve as well. And then, there's certainly, this list is quite long. Again, it's important to distinguish syncope from traumatic falls. And again, taking a good history is often paramount. But I think the fundamental evaluation in these patients in distinguishing cardiac from non-cardiac causes is start with the basic three. Take a very detailed history, a very detailed cardiovascular exam, do a 12-lead EKG. If there's any suspicion that this could be cardiac in etiology, typically the next test is going to be an echocardiogram. You want to, unfortunately, the majority of patients who have malignant arrhythmias, they have so in the setting of structural heart disease. And an ultrasound of the heart called an echocardiogram will be very good at distinguishing whether someone has structural heart disease and is at high risk for malignant arrhythmias like ventricular tachycardia, or if they don't have structural heart disease, this makes these serious things less likely. Obviously, hopefully a 12-lead EKG will help you diagnose significant bradycardias, but occasionally we'll do other testing when directed by the history or physical exam, such as exercise stress testing if someone has exertional syncope, or perhaps even outpatient monitoring where people wear a monitor for a few weeks to see if perhaps we can detect an arrhythmia that might be causing this. Now, it's important to note that in patients who have clear vasovagal syncope, for example, they have a prodrome that I described earlier, they saw blood, they passed out, they have a normal history, otherwise that does not suggest any of these causes, their EKG and exam are normal, we'll often stop the evaluation right there. It's also important to note that there are some red flags that should raise your concern. These are people who will often admit to the hospital. So anybody who has a history of coronary artery disease or a prior myocardial infarction who passes out is a very high-risk patient and raises the likelihood that they indeed have ventricular tachycardia as a cause for syncope. Obviously, in the setting of a patient with known congestive heart failure who has known structural heart disease, then that's a patient we're typically going to admit to the hospital and evaluate very carefully because, again, the likelihood is that this is true cardiac syncope. And I think thirdly, if you have somebody who has exertional syncope, they pass out during the act of exercise, particularly those who have no warning, that significantly raises the likelihood that this was a tachyarrhythmia or a bradyarrhythmia or something very serious. And that is another red flag, as is sustaining severe injuries during syncope, where people had no warning, they could not break their fall. And those are all reasons to admit someone to the hospital and consider doing a little more extensive workup to include an echocardiogram to evaluate those patients. So that's a real quick down and dirty approach to syncope. I think this is a real simple way to divide this up, and I hope this helped, and good luck.